throughout this entire presentation, one thing is going to be very, very common, and that's the approach. So for every sick patient, every patient who looks to unstable to you, who may have impending sort of, life-threatening complication, would imply that you approach them to the ABCD approach. How do we manage actually with the ABCD approach? As you can see on the screen, any patient who's talking to you, maybe, if you're interacting with him and he's replying you back, the airway is patent. If he's not replying back, or you have additional sounds in the form of gargling, or any other form of snoring, so these stridor, these indicate that the airway has been compromised. The compromisation could be because of a foreign body, because there may be some vomitus, there may be some cervical spine trauma. We don't know the exact reason when you see a patient. But most of these patients would be either unconscious, brought in with a trauma, whatever the case may be. If the airway is not patent, you have to insert an advanced airway. A GCS less than 8 with a compromised airway, you have to go and insert an advanced airway. So for instance, now a patient comes to you and who's constantly snoring. Okay, how do you approach him? So you do a very, very basic thing, which we call as a airway maneuver, you change the position of the airway basically. So what do? Either you do a head tilt chin lift, or you do a jaw thrust. Jaw thrust should be done if a patient is of any trauma and you're suspecting a cervical injury. Otherwise, you could do a head tilt chin lift. For instance, you think that the patient might be having blood or vomitus or something in his mouth, you could do a suctioning of the oral airway with a suctioning machine. Basically, if you don't have any suction machine, just leave it. Okay, don't do a blind basic, suctioning, or blind finger insertion to looking for the foreign objects. And after you've done this, please start patient on the oxygen if the patient looks to have a compromised airway. We come to the breathing now. So for every breathing, you need to check how is the breathing rate going, how's the breathing pattern, the breathing effort, whether the patient looks cynosed, whether he's using the accessory muscles, how is it overall going. So basically, after you've done this, the inspection, palpation, percussion, auscultation, everything, yes, go ahead with it, no worries. But make sure that if the patient looks cynosed, if the patient is not breathing, these are the warning, the red flags for us. So if you've got a saturation probe, just put it on the saturation probe. During the COVID era, the slow sats, the happy hypoxia was a very, very mysterious concept, but that's only for COVID. For all other diseases, which still say just check the sats. If the sats are low, you have to supplement some oxygen. If the patient is not breathing, you have to start giving artificial respiration to the patient. If you can't find an air entry on one side, for instance, the patient had a trauma or something, if you find that the trachea is not central, it's moving to one side, always suspect a tension pneumothorax. If you can, order a chest x-ray, get a ABG. But if you're sitting in a periphery setup and the patient comes with this, and you are very sure that this could be a tension pneumothorax, just do a needle decompression. That's it. We come to C, which is circulation. Circulation, you just see the patient. If the patient is bleeding, how the patient is, what's the color of the patient? Whether the patient looks mottled, he looks pale, how's the overall condition of the skin. If the patient is cool, he's warm, sweaty, dry, just auscultate the heart, just see, no one is going to ask you what sort of murmur are you hearing. But if you can hear no heart rate, that's a warning sign. If you can hear that the heart rate, you can find that the pulse is very low, very high. These are the warning flags that you need to be, taking care of. So do a capillary refill time. It's more than 3, things should be settled. If it's more than, not, if it's going more, it's not bad. So if it's less than 3, it should be normal. If it's more than 3, it's very abnormal. Meanwhile, also check the blood pressures, pulse, and ECG of the patient if possible. ECG is very, very important. It gives us a lot of information. Plus, while you're assessing the circulatory parameters, if you find that the patient has any of the unstable signs, the red flags, just get an IV line in place, get some bloods, draw some bloods, start some IV fluids. If you can't get the IV access, for instance, like in the UK, they use a lot of IO access. Any patient who's coming in crashed without like a road traffic accident, you can't file the peripheries, you can't find the IV lines. They directly go for intraosseous access. In India, we still don't do it much. So once you've done the 12 lead ECG, get the blood tests, get the urinary catheter. Like if your patient is unconscious, if the patient looks to be in shock, and look septic, toxic, just get a catheter in. If not, no one's gonna tell you, but if you can, it improves our overall management of the patient. If you can, get a echo, a fast scan, whatever. If you don't have, no worries. Once you've done the circulatory check, you go for the disability check. You check basically whether the patient is alert, getting response to your voice, pain, or unresponsive, that we term as AVPU. Check the pupils of the patient, check about the neck stiffness of the patient. One more thing in a disability, we all would go and bombard the patient with GCS, calculate the GCS, but most of us would forget about the blood sugars. Diabetes is becoming a rampant disease in India. So many patients who are unconscious, hypoglycemia can also be the reason. So don't forget about it. If the patient looks to like unresponsive to you, or the GCS is less than 8, but the patient is breathing well, the circulatory parameters are well, just put them on a recovery position. Then I would come back to the exposure. So expose the patient, which we usually don't do in India. So expose the patient from head to toe. Look for any abnormal signs, any bruise, petechiae, bleeding signs, any lesions, burns, anything out of the blue, just check it. While you're doing the exposure, make sure that you maintain the temperature of the patient. What we do is we usually expose the patient. For instance, a patient had a road traffic accident, we expose them, and the hypothermia clicks in, and then it makes things more complicated. And if you're suspecting that the patient might be having underlying sepsis, ask for blood cultures. If not, give antibiotics. If not, proceed ahead. So this is the common pathway that we'll be dealing with